Welcome to the Deep Dive. Today we are digging into some really critical players in digestion and metabolism. The liver, the gallbladder, and the exocrine pancreas. These aren't just accessories. They're like the body's metabolic command center, detox factory. Just absolutely vital.
That's a great way to put it. They're so interconnected, too. And our goal today isn't just definitions, right? We want to unpack the pathophysiology, how things actually go wrong, step by step, leading to disease, so you can really grasp the mechanisms.
Right, the how. Let's kick off with the big one, the liver. It's huge, isn't it? About 1.3 kilograms, largest internal organ. But what's really key, pathologically speaking, is its blood supply. It's got this dual thing going on.
It really does. About 25% is standard arterial blood from the hepatic artery, bringing oxygen. But the other 75%, that's the game changer. It comes from the hepatic portal vein.
Straight from the gut.
Exactly, collecting pretty much everything that's just been absorbed, all the nutrients, hormones, but also, importantly, any toxins or bacteria. The liver gets the first shot at processing all of it.
The gatekeeper.
Precisely. And inside its functional units, the lobules, you have these specialized macrophages called Kupffer cells. Think of them as the bouncers grabbing bacteria and foreign stuff right out of that portal blood. They're the first line of defense there.
Okay, so it's filtering, but its main job is metabolism, right? Just this massive range of functions. Let's talk energy first, carbohydrates. How does it keep our blood sugar stable?
Yeah, it's like the body's glucose thermostat. If your blood sugar's high after a meal, the liver stores that excess glucose as glycogen. That's glycogenesis.
Storing it away.
Yep. Then, if your blood sugar drops, say between meals, it breaks down that stored glycogenolysis.
Releasing it back.
Right. And if you fast for longer, or if glycogen runs out, it can actually make new glucose from other things like amino acids. That's gluconeogenesis. Super important for keeping the brain fueled.
Wow, okay. Biz with cards. What about proteins? I know make some really important ones.
Absolutely crucial ones. Think albumin, that's the main protein in blood plasma, keeps fluid where it should be, transports stuff. And then the blood clotting factors like fibrinogen, prothrombin. Many key ones are made only in the liver.
So if the liver's failing, you see swelling because of low albumin and bleeding problems because of low clotting factors. Makes sense.
Exactly. But maybe the most critical daily job related to protein is detoxification, specifically dealing with ammonia.
Ah, ammonia.
Well,
why is that such a big deal?
Well, when your body breaks down amino acids from protein, ammonia is a byproduct. And ammonia is seriously neurotoxic. It can cross the blood-brain barrier and cause major CNS problems.
Okay, so the liver has to get rid of it.
Immediately. It uses the urea cycle to rapidly convert that toxic ammonia into urea, which is relatively harmless and easily excreted by the kidneys. This detoxification is constant and absolutely vital for neurological function. We'll come back to this when we talk liver failure.
Got it. Urea cycle handles the ammonia. What about fats, lipids?
The liver processes fats, too. It breaks down free fatty acids for energy, turns them into keto acids. It also synthesizes cholesterol, which we need for membranes and hormones, and lipoproteins like LDLs to transport fats around the body. If you eat way too many carbs, the liver actually converts that excess into triglycerides for storage.
Okay, so it's making things, storing things, converting things. Now let's talk about what it secretes. Bile. What's that all about?
Right, bile production is a major function, about 500–600 milliliters a day. Bile is mostly water, but it contains bile salts, cholesterol, and bilirubin waste products. The bile salts are key for digestion.
How so?
They act like detergents. They break down large fat globules in your food into tiny droplets forming micelles. This emulsification is essential for your enzymes to actually digest the fat, and crucially for you to absorb the fat-soluble vitamins A, D, E, and K.
Okay, so bile flow is critical. What happens if it gets blocked or slowed down?
That state is called cholestasis. It means bile standing still, basically. It can be caused by problems inside the liver, like swollen liver cells, or outside the liver, like a gallstone blocking the bile duct.
Intrahepatic or extrahepatic?
Exactly. And the consequence is that stuff meant to leave in bile, bilirubin, cholesterol, those bile acids, starts backing up into the bloodstream.
And what does that feel like for the patient? Is there a common symptom?
Oh, yeah. The most common and often most distressing symptom is pruritus, intense, widespread itching. We think it's caused by those elevated bile acids irritating nerve endings in the skin.
Itching from bile acids?
Yeah.
Okay. But the most visible sign of this kind of backup is usually jaundice, right? Let's trace bilirubin. Where does it come from?
Bilirubin is the breakdown product of heme, mostly from old red blood cells. Initially, it's released as unconjugated bilirubin. This form isn't water-soluble, so it has to bind to albumin to travel in the blood to the liver.
So it hitches a ride on albumin.
Correct. Once inside the liver cell, the hepatocyte, the liver does its magic. It conjugates the bilirubin, basically attaching a molecule to make it water-soluble.
Got it. Conjugated bilirubin, water soluble.
Right. Now it can be secreted into the bile. From there, it goes into the intestine, where gut bacteria convert it into urobilinogen, most of which is excreted in feces, giving stool its color. Some gets reabsorbed and excreted by the kidneys.
Okay, so jaundice or icterus happens when that pathway gets messed up.
Oh, exactly. When bilirubin levels in the blood rise usually above 2.0 to 2.5 milligdl, it starts depositing in tissues, causing that characteristic yellowish discoloration. And you often see it first in the sclera, the whites of the eyes.
Why the eyes first?
The sclera has a lot of elastic tissue, and bilirubin seems to have a high affinity for it. It just shows up there early. Now, for figuring out why someone is jaundiced, we often think about it based on location where the problem is.
The classifications. Prehepatic, intrahepatic, posthepatic.
That's right. Prehepatic jaundice means the problem is before the liver. Usually it's excessive red blood cell breakdown hemolysis. Think sickle cell crisis or a bad transfusion reaction. The liver's working fine, maybe even overtime, but it just can't keep up with the sheer amount of unconjugated bilirubin being produced.
Overwhelmed.
Totally overwhelmed. Then there's intrahepatic jaundice. Here, the problem is inside the liver itself. The liver cells are damaged, maybe by hepatitis, cirrhosis, or certain drugs, so they can't properly take up, conjugate, or secrete bilirubin. You might see a mix of elevated, conjugated, and unconjugated bilirubin here.
And the last one, posthepatic.
That's an obstruction after the liver, in the bile ducts. Think gallstones stuck in the common bile duct, or maybe a tumor pressing on it. Bile simply can't flow out into the intestine, so conjugated water-soluble bilirubin backs up into the blood.
Okay, that makes sense. Location tells you a lot about the likely cause.
It's a really useful framework.
Right. Let's shift focus slightly to how the liver can get injured. Its role as the detox center makes it vulnerable, especially to drugs, right? Hepatotoxicity.
Hugely vulnerable. It's the first stop for many ingested substances, especially lipid-soluble ones that the body needs to make water-soluble for excretion. It generally uses a three-phase process.
3 phases.
Yeah. Phase 1 involves chemical modification, often oxidation or reduction reactions. Frequently using the cytochrome P450 enzyme system, you hear about CYP enzymes a lot with drug interactions.
Right, the CYP system.
Phase 2 is conjugation. This step attaches another molecule like glutathione, glucuronic acid, or sulfate to the phase 1 product, making it much more water-soluble. Phase 3 is just pumping that water-soluble conjugate out, usually into the bile.
Okay, phase 1 modify, phase 2 conjugate, phase 3 excrete. How does something like an acetaminophen overdose break that system? It's a classic example.
It's a perfect example of overwhelming phase 2. Normally, acetaminophen is safely conjugated, mainly with glucuronide and sulfate. A small amount goes down a CYP pathway to a toxic intermediate, but that's quickly neutralized by glutathione.
Okay, glutathione handles the toxic bit.
Under normal doses, yes. But in an overdose, the main conjugation pathways get saturated, and more acetaminophen gets shunted down that toxic CYP pathway. At the same time, the massive load rapidly depletes the liver stores of glutathione.
So you run out of the neutralizer.
Exactly. The toxic intermediate builds up, binds to liver cell components, and causes massive centrilobular necrosis, widespread liver cell death. That's why the antidote, N-acetylcysteine, works. It basically acts as a precursor, helping the liver replenish its glutathione supply.
Wow. A predictable dose-dependent toxicity. But not all drug reactions are like that, are they? Some are idiosyncratic.
Right. Those are unpredictable. They don't seem related to the dose, might happen in only a few susceptible individuals, and often have features suggesting an immune or allergic reaction. Much harder to anticipate.
Okay, drugs are one major hit. What about viruses? Viral hepatitis.
Still a huge global health problem. We know of 5 main hepatotropic viruses, hepatitis A, B, C, D, and E. They all cause acute liver inflammation, but they differ a lot in how they spread and their long-term consequences.
Let's talk about that acute phase first. It usually follows a pattern.
Yeah, typically 3 phases. The prodromal phase comes first. You feel generally unwell, maybe fatigue, nausea, muscle aches. Liver enzymes like ALT and AST start to rise. Then comes the icteric phase. That's when jaundice appears, the liver might be tender, urine gets dark. Finally, the recovery phase, where symptoms subside and liver function returns to normal. Hopefully.
Hopefully. But the big difference is in who recovers fully versus who gets chronic disease, right? Let's contrast HAV/HEV with the others.
Okay. Hepatitis A and hepatitis E are typically spread through the fecal-oral route contaminated food or water. They almost always cause acute hepatitis, and the body usually clears the infection completely. There's generally no chronic carrier state, although HEV can become chronic in severely immunocompromised people.
So usually self-limiting for A and E.
Yeah.
What about B, C, and D?
These are the ones we worry more about long-term.
Yeah.
HBV, HCV, and HDV, which only infects people already infected with HBV, are spread through blood and body fluids, needles, sex, mother to child.
And the big risk here is
Chronicity. A significant percentage of people infected with HBV, and especially HCV, fail to clear the virus. They develop chronic hepatitis, becoming long-term carriers. This chronic inflammation over years, decades even, dramatically increases the risk of developing cirrhosis and hepatocellular carcinoma, primary liver cancer.
so B, C, D equals bloodborne, risk of chronic disease, cancer risk. We can track HBV infection with blood tests,
Right.
like HBsAg.
Yes, serologic markers are key. HBsAg, the surface antigen, indicates active infection. The person is infectious. Seeing anti-HBs, the antibody to the surface antigen, means they've either recovered from infection or, more commonly these days, they're protected due to vaccination.
Okay, vaccination for HBV is crucial then. Now, you mentioned cirrhosis. That seems like the end point for a lot of chronic liver damage. What exactly is cirrhosis?
Cirrhosis is essentially the final common pathway for many chronic liver diseases: chronic viral hepatitis, alcohol abuse, fatty liver disease. It's defined by the replacement of normal liver tissue with diffuse fibrosis, scar tissue. This scar tissue forms constricting bands that break up the normal liver architecture into regenerating nodules. It's irreversible.
Scar tissue replacing functional tissue. And that scarring directly leads to a major complication.
Portal hypertension, right, PHT.
Absolutely. Think of the liver like a sponge that blood flows through easily. In cirrhosis, that sponge becomes hard and scarred. It increases resistance to blood flow coming from the portal vein. This backup causes a sustained increase in pressure within the portal venous system. That's portal hypertension.
Like a dam blocking the river. And that pressure backup causes downstream problems. What are the main consequences? 3 big ones stem directly from PHT. First, ascites. Fluid leaks out of the congested portal capillaries into the abdominal cavity. This is made worse because the failing liver also can't produce enough albumin. Low albumin means lower oncotic pressure in the blood, so there's less force pulling fluid back into the vessels.
So high pressure pushing fluid out, low protein failing to pull it back in, double whammy causing fluid buildup.
Exactly. Second complication is splenomegaly. Blood backs up into the splenic vein, causing the spleen to enlarge. An enlarged, congested spleen often becomes overactive hypersplenism, destroying blood cells faster than usual, leading to anemia, low platelets, low white cells.
Enlarged spleen chewing up blood cells. What's the third, often most dangerous consequence?
Portosystemic shunts. The body tries to relieve the high portal pressure by diverting blood away from the liver through alternative collateral veins that connect the portal system to the systemic circulation.
Creating bypass routes.
Yes, but these bypass routes aren't designed for that pressure or volume. The most dangerous are esophageal varices. These are dilated, thin-walled veins in the esophagus. They can rupture easily under the high pressure, causing catastrophic, often fatal bleeding. You might also see visible dilated veins on the abdomen called caput medusae.
Esophageal varices is terrifying. Okay, so cirrhosis leads to PHT, which causes ascites, splenomegaly, and dangerous shunts. What happens when the liver function itself just fails?
That's liver failure. It typically means about 80–90% of functional capacity is lost. And one of the most devastating consequences is hepatic encephalopathy, or HE.
The brain effect. We touched on ammonia earlier. Is that the main culprit here?
It's considered the primary neurotoxin involved, yes. When the liver fails, it can no longer detoxify ammonia coming from the gut. Ammonia levels rise in the blood, cross the blood-brain barrier, and interfere with neurotransmission, causing a spectrum of neurological symptoms, confusion, personality changes, neuromuscular issues.
Yeah, the classic sign we look for.
Ascites, that characteristic flapping tremor you see when the patient extends their wrists. It's not specific just to HE, but it's highly suggestive.
So treatment for HE focuses on lowering that ammonia.
Primarily, yes. We use medications like lactulose, a non-absorbable sugar that gets broken down by gut bacteria. This acidifies the colon, trapping ammonia as non-absorbable ammonium ions, promoting its excretion. We might also use antibiotics like neomycin or rifaximin to reduce the number of ammonia-producing bacteria in the gut.
Okay, tackling the ammonia load. Let's quickly cover the gallbladder and pancreas to round things out. Gallbladder's job seems simpler.
Relatively, yeah. Its main role is to store and concentrate the bile produced by the liver. When you eat, especially fatty foods, the hormone polycystic CCK, is released, signaling the gallbladder to contract and squirt that concentrated bile into the small intestine to aid digestion.
And the main problem here is gallstones cholelithiasis. What are they usually made of?
About 80% are primarily cholesterol stones. They form when the bile becomes supersaturated with cholesterol, usually because there's too much cholesterol or not enough bile salts to keep it dissolved. Bile stasis, sluggish flow, also contributes, which is why they're more common during pregnancy or rapid weight loss. Inflammation plays a role too.
So stones form. What happens when they cause trouble? What's biliary colic like?
It's typically sudden, severe pain, usually in the upper right abdomen, often radiating to the back or right shoulder blade. It's often triggered after eating a fatty meal because the gallbladder contracts against the obstructing stone in the cystic duct or common bile duct. It can be excruciating, but often subsides if the stone moves.
And if the stone doesn't move and the duct stays blocked?
That leads to inflammation of the gallbladder itself. Acute cholestasis usually requires intervention.
Okay. Finally, the pancreas. We're talking exocrine pancreas here, the digestive enzyme part.
Right. Its job is to produce potent digestive enzymes, amylase for carbs, lipase for fats, and proteases like trypsin for proteins. Critically, it secretes these enzymes in an inactive form. They only get activated once they reach the duodenum. The pancreas also produces a trypsin inhibitor as a backup safety mechanism.
To prevent self-digestion.
Exactly, because acute pancreatitis is essentially that. The premature activation of pancreatic enzymes, especially trypsin, within the pancreas itself, these activated enzymes start digesting the pancreatic tissue, causing inflammation, necrosis, and intense pain. It's a reversible process, hopefully.
What usually triggers that premature activation?
The two biggest culprits by far are gallstones temporarily blocking the pancreatic duct outlet and alcohol abuse. How alcohol does it is complex, but it's a major cause.
And the classic symptom?
Severe, constant epigastric or periumbilical pain, often described as boring straight through to the back. It can be incredibly intense. Severe cases can lead to systemic inflammation, shock, and multi-organ failure. It's potentially lethal.
And if the damage isn't reversible, if it keeps happening?
That leads to chronic pancreatitis. This is progressive, irreversible destruction of the pancreas with fibrosis and scarring. The most common cause, overwhelmingly, is long-term alcohol abuse.
And the long-term consequences of losing pancreatic function.
As pancreatic tissue is destroyed, you lose both functions. Loss of the endocrine islets leads to diabetes mellitus. Loss of the exocrine enzyme production leads to severe malabsorption, particularly of fats, resulting in steatorrhea, bulky, fatty, foul-smelling stools, and weight loss.
Okay. Before we wrap up, a quick word on cancers in these organs.
Important to mention, primary liver cancer, hepatocellular carcinoma, HCC, arises from hepatocytes and is strongly linked to chronic HBV and HCV infection and cirrhosis from any cause. Cholangiocarcinoma is cancer of the bile ducts.
And pancreatic cancer.
Pancreatic adenocarcinoma is unfortunately quite common and very deadly. It's the fourth leading cause of cancer death. It's often diagnosed late because symptoms like vague pain and weight loss are insidious. Jaundice might occur if the tumor is in the head of the pancreas, blocking the bile duct. Prognosis remains poor. A characteristic feature sometimes reported is pain that's worse when lying down and may be slightly relieved by leaning forward.
A grim note to end on, but crucial context. So we've covered a lot: the liver's metabolic dominance and detox role, the biliary system's flow dynamics, the pancreas's enzymatic power, and how failure or obstruction in one area impacts everything.
It really highlights the interconnectedness. Liver failure impacts brain function via ammonia. Bile duct obstruction causes jaundice and itching. Pancreatic enzyme activation leads to self-destruction. It's all tightly linked.
That example you mentioned earlier sticks with me: a tiny gallstone causing a cascade. Jaundice from bile blockage, then potentially pancreatitis if it obstructs a pancreatic duct too. It underscores how precarious the balance is, particularly that constant ammonia detoxification by the liver.
It really does. Millions of chemical reactions per second just to keep things stable.
So maybe the final thought for you listening is this. We talked about the liver needing to convert neurotoxic ammonia constantly. Now that you understand the pathways, think about the sheer vulnerability. If just one key enzyme in that urea cycle pathway significantly malfunctioned due to a genetic issue or damage, what would the immediate biochemical and clinical fallout look like? It really emphasizes the precision required.
It's a system that demands constant vigilance. We hope this deep dive has helped clarify these complex processes. Keep digging into the material.
Absolutely. Thanks for joining us on the deep dive. We'll catch you next time.